One of the things that we as humans feed off of is the feedback we get from others. And so you have to take a moment in these less emotional moments to take stock of who do you feel good around? Who
Mm-hmm.
fills your bucket? Because those are the people that you should try and dive into spending more time with.
So, welcome. I am very excited for you all today to have the experience with Dr. Amy Swift, who is out of New Canaan, Connecticut at Silver Hill Hospital, has been in the world of addiction specialty, comes from a holistic approach to all of this with mental health, addiction, trauma, so on and so forth, deals with inpatient services at her hospital as the deputy, what was it? Deputy
Deputy
Chief
Chief Medical
Medical
Officer.
Officer. There we go. Okay, it's a mouthful. But what I love about her is there's a passion here. There is a deep desire to, at this point, also give back and open the door and the window, kind of pull the curtain back for those of us who love someone dealing with substance use disorder, so that we have access to actually a doctor who's in this field. And we don't normally get that kind of access. We might have access to a family care weekend or a day or something along those lines, but this is an opportunity for our listeners to have an opportunity to hear your side of the aisle and your side of the story. And so I always want to start with, how'd you get here?
It's a great question. And the thing that honestly sticks out to me is that when I first started, right after college, I worked in a forensic unit, in a forensic psychiatric unit. So in a prison system in the middle of Manhattan. And what I noticed there is that the patients that came in struggling with substances they were there for psychiatric reasons, but struggling with substances, they were the ones that struggled the most. That kind of lived in the back of my mind. And then fast forward a couple of years later, I went back to school. I went to med school. I got through med school. And in my second year in residency, I was on a dual diagnosis unit. So a unit for people that are struggling with mental health and addiction. And I noticed the patients that had the most addictive behaviors were the patients that the doctor struggled with the most. So it kind of set something off in me that I wanted to be the doctor that could do it all. I never wanted to be the one that had to refer to somebody else because this patient was too complex or had this contributing factor. So I went and did an addiction fellowship, and lo and behold, I became, in my system, the doctor you called when you had that really difficult patient. And so they would call Dr. Swift, and this young woman would show up and they'd be like, "You're Dr. Swift?" But it's how an addiction doc was born.
Okay. Well, I love your sense of curiosity. That's big on my list too. And so I love how curiosity leads you down a path that you didn't know you were going to walk down. And so I'm going to ask, like, from a personal perspective, have you had any family members or friends or family that have been dealing with substance use disorder or?
So that's a question that I used to get all the time when I first
Yeah.
started. They would ask, "Why addiction? Do you have a personal experience with it, a family member?" And the answer is
Yeah.
actually no. I don't
Hmm.
have any direct family members. Of course, I have friends and family members of friends that have had severe addiction, but
Yeah.
not in my immediate circle or in
Wow.
my personal life. But what's really interesting about that is those questions
Hmm.
actually stopped from the patients. It no longer mattered that they
Hmm.
felt like I understood them, even though I hadn't walked or lived that life.
Right. Wow. I love that because we don't have to walk the walk to be able to love, see, and hear someone.
Right.
And when we're curious and we're unpacking all these doors of understanding and staying in that curiosity, because obviously things are changing, I'm going to ask you about that in a minute, is they just care about them, honestly.
That's all. It's authentic compassion for the person in front of you. As long as you can
Yes.
have authentically compassionate feelings for what they're going through, it doesn't matter if you personally understand it. That's my take
Right.
anyway.
Yeah. Yeah. Well, I'm with you on that for sure. And so I am super curious again, like, what do you wish you'd known back when you started that you actually really know now?
One of the things that has been most useful, I think, is bringing families of loved ones in early. When I first started, I don't think I had the confidence to do it in the way I do now.
Hmm.
But being able to have those early conversations that may be incredibly hard, the meetings may be really dysregulating, honestly, for the family than for the patient.
Yeah.
But if you rip the band-aid off early and start the talks with everybody together as a team, usually by the end of whatever treatment episode you're in, you can find some common goals and people can feel supported.
Yeah.
But it's something that really has to start at the beginning.
Yeah, I'm in agreement there too. And so, what's your common experience when the family is involved? Like, how do they normally kind of enter the room in the beginning?
Traumatized. They are coming in so scared. They are coming in angry. They're coming in fearful. There's the identified patient, but I'm typically sitting on the side of the room with the family
Hmm.
because they're resilient. They've been through so much more than we can even imagine or that they've
Right.
even told us. But the family is raw. They are constantly in this state of panic that they're, particularly with opiate use disorder, that they're going to get that call that there was an overdose and their loved one has died. And so they are coming in shells of themselves.
Yeah.
It's something where I find that the first conversation has to just be kind of dissipating the energy in the room.
Good for you. That's awesome. And so, what are kind of the first few steps to dissipate that energy, but also kind of open the possibility for doing it a different way?
So the first thing I have to ask is I have to ask the mom what it's like, the loved one, the spouse, whoever it is. What is it like to see your person in this
Hmm.
space right now? What are the
Hmm.
feelings that are coming in? Because if we can sit in the here and now of what the emotion is, then we
Hmm.
can start to unpack how this can be different going forward. Because
Hmm.
what they're coming in is this pattern of fear, anger, like I described. But what they're
Hmm.
feeling usually when they see the person in the room is relief. They
Yeah.
feel a little bit of that love
Hmm.
sparkles through. So I
Hmm.
have to remind them that that is living in there and build the
Hmm.
hope. And sometimes I have to hold the hope to start that that can
Hmm.
come back.
Yeah. And so this was my experience is the first time Sam went into rehab, we thought, "Oh, great."
Yeah.
And now what we know now is, I mean, Sam was in and out of treatment 12 times, but the average is 5 to 6 or 7. And so how do you help people kind of understand more about the addict's journey, but at the same time, what's our journey in this? How do we stay sane in the midst of the ups, the downs, the sideways, all the chaos?
Well, one of the things I think is exactly what you described. We have to start with the psychoeducation for the naive family member. When they have the patient's first episode of treatment, this is a lifelong disease. You don't get diagnosed with diabetes and never have high blood sugar again. You don't get diagnosed with hypertension and never have high blood
Hmm.
pressure again. These are things that are going to ebb and flow. So we have to be very kind of definite about the idea that this may not be it, that we are going to describe. I always ask permission before I give psychoeducation, but may I share with you what could the next couple of years could look like? And once they give me permission to share it, I'll say, we're really glad to start building a foundation right now. But as all things, we don't expect to walk the rest of our lives without ever tripping again. There may be a slip, there may be a detour. We will talk about how to prepare for that, but let's be realistic about setting short-term goals right now so that they're
Yeah.
attainable.
Yeah. Okay. And I'm going to assume, but I'm going to ask you anyway, because for me, it was I really needed to create a regimen of self care.
Yeah.
And so, where are you on the layers of self care that need to take place in order for us to maintain our sanity?
Well, that I actually was speaking on our Silver Hill radio yesterday about this, is that we really have to delineate the roles. Addicted patient is to be a loved one, not the therapist, not the doctor, not the
Hmm.
sober coach. It really has to just be the loving support. And sometimes that means that you can't get dragged into dangerous situations.
Right.
You can't be somebody that's going to save them if they owe money to somebody and they're about to get beat up because they owe money. That's not the role of mom, for example. And that has to be part of the explicit conversation. So that's some of the things that I would talk about in the room with the family and the patient is
Mm-hmm.
saying, let's talk about what I'm recommending mom does from here, on out. And that's going to be that mom receives your phone calls, tells you she loves you, and maybe sets a boundary on interacting with you if you're intoxicated, because that's not good for mom. And we talk a lot about explicitly about the trauma, that the compounded and just kind of low level but constant trauma of having a loved one that is unstable at this point, and that you have to give mom some grace that every call feels like it could be that call. And
Mm-hmm.
so she's not going to ever be able to discard that entirely, but hopefully if things start to
Mm-hmm.
stabilize, then that'll minimize and it won't have as much
Mm-hmm.
impact on her as right now. But
Yeah.
really, really being prescriptive about what roles are appropriate for the loved ones and what are not.
Well, there's two things that are going through my head. One is that it's just a courageous act to love somebody who's suffering. and witness those that we love that are in suffering. And we have to change the mommy code. We can't fix it. We can't save them. All these things that we've been told that we're supposed to do. We're supposed to keep them safe. We're supposed to control the situation, and that mommy code and daddy code really has to be completely reimagined.
I mean, I say that to them. I say, I can't prescribe sobriety. You have to choose it. And I say that to the loved one too. I said, Mom, you can't keep him away from alcohol, cocaine, whatever it is. He has to choose it. These are things that, although seem exactly like you're saying, like it obvious, but we have to remind ourselves because although, yes, it should be obvious, society still kind of says like a little bit of, okay, go save him, right? Or take care of this person. Or we say to the patient, why are you doing this to yourself? You have all these great things, but they're not
Hmm.
choosing to live this life. Nobody
Hmm.
woke up one day and said, I want to be addicted to opiates. It's something that, as you've described and you've lived, sometimes it lives in their DNA and things just happen where it comes to fruition, but they don't want this. So we have to
Hmm.
understand that they don't want it and we can't control it. They have to take some tools to build the house to control it.
And on both sides of the aisle, whether it's the person dealing with substance use disorder or whether it's the family or friends, shame is right smack in the middle of it usually.
It's shame is one of the things I tell people this, and I actually tell my own kids this all the time. Emotions last for 90 seconds, right? Like we
Hmm.
live in these feelings of embarrassment, shame, all those things for less than 2 minutes. But what we do with that moment
Hmm.
is what we remember. So if you allow the time to let that emotion dissipate and don't consolidate it and amplify it, then it'll go
Hmm.
away. But
Hmm.
if we get hooked into that shameful feeling and we double down on what we're doing around it, then it's going to live stronger and imprint
Hmm.
on, our day to day.
Yeah. So again, and I actually just read this. I remember what the thing, because I'm listening and reading all the time. But I just read the 90-second thing about emotions. I was like, oh, okay, that's really powerful information. So thank you for that. And then kind of on the other side of that, if you find yourself stuck in shame, and also who you're surrounding yourself with really matters here. Can you speak to that a little bit? Because I know that I had to reconfigure who was surrounding me.
It's a really great point because one of the things that we as humans feed off of is the feedback we get from others. And so
Hmm.
you have to take a moment in these less emotional moments to take stock of who do you feel good around? Who
Hmm.
fills your bucket? Because those are the people that you should try and dive into spending more time with. And if there are people where you're finding negative emotions are creeping up, not by fault, they're not purposely doing it, they're not saying anything mean, but you're finding that you're feeling more shameful, more embarrassed, there are just a heightened state of awareness around them, around what you're saying, just take stock of that and try and balance out those interactions, minimize the, keep them shorter. Not about cutting them out of your life, but knowing when you can tolerate that level of distress and when that may be
Yeah.
just the straw that's going to break the camel's back for the day. And give yourself
Right.
the grace to say, I don't need to engage with that person today in a long, meaningful way.
Yeah. Well, I know a long, long time friend believes that I should be able to control this. And so I really had to do distancing around this because that was not a mindset that I wanted to give any energy to. And they weren't willing to be curious about knowing it any other way.
That's part of what I oftentimes talk with families about that are still in the mindset that they can control it is that a lot of the work is actually getting them to join with me in the idea that they cannot control it. I
Hmm.
had a young girl, she was 19 and she was adopted and she had a really bad alcohol use disorder, really, really severe. Um, Definitely lived in her genetics. And I sat with her adoptive parents who were lovely. They were incredible people. And
Hmm.
they kept saying to me, why can't she just have one drink? Like, let's just get her back to the point of having one drink. And I said, that's not her destiny. She has
Hmm.
already shared with us that she cannot control her use of alcohol.
Hmm.
She was also a vegan. I was like, so you guys will allow her to make a choice about what food she's putting in her body, but you don't want her to have that same choice about whether or not she consumes alcohol. Share with me what the
Mm.
difference is.
Oh, wow. That
Um,
was great.
and they finally started to see, like, okay, if we're going to not fight her on the choice of what she eats, why are we fighting her on the choice of whether or not she uses alcohol? But
Right.
they really they had this stuck idea that she should be this quote normal 19-year-old that can have a drink.
Yeah, and so we have all these stories that are rolling around our heads that we don't normally kind of stop to tease apart to better understand. And one of them for me was really getting clear, and this is how I chose to frame it was that who I know my son to be and who he really is, not the person that I experience when he's using. And so I differentiated them as two different beings. And I think of the addiction part of that as it's got him hijacked.
Right. It has, but that's true. Chemistry, brain chemistry wise, he's making decisions from a different part of his brain when he's actively using. This is something that we've seen with fMRIs, with brain studies and everything, but it's also very, very obvious in when you see news media of the mom that overdoses with the kids in the backseat of her car. As a
Mm-hmm.
mom, you know that no one's ever choosing to
Mm-hmm.
let toddlers or babies be in the back of the car unattended. It's a different decision point that is driving the brain when they're using
Mm-hmm.
opiates. It really,
Mm-hmm.
it 110% is. And that's another thing. I mean, even alcohol too, but this is another thing that I often have to describe to families is people come into our inpatient setting and they'll do a detox. And I actually had this conversation with a gentleman yesterday. I said, the detox didn't do anything for your relationship with alcohol. The detox safely allowed you to stop drinking in the way you were without having a seizure and potentially leading to death. I said,
Mm-hmm.
the relationship with alcohol is absolutely the same as it the day you walked in. That's what rehab is for. And
Mm-hmm.
rehab isn't just about developing skills and tools and all of that, but it also gives your brain a break from the cues and the interactions with alcohol such that you can start to make choices from the prefrontal cortex again, as opposed to your
Mm-hmm.
midbrain, which is making these animalistic choices driven by reward and
Mm-hmm.
cues. It's twofold. It's really about the skills and the time to allow your brain to rewire a bit.
Yeah. Well, I know in this last round of Sam being clean and sober, it's now been 27 months. I pretty much had it in my head that I needed to wait at least 18 months to really kind of begin to rediscover him again from a place where he could make better decisions and his brain will be healthier, but also he's also on the track of recreating habits that rewire his neural pathways so that I'm really beginning to get, well, Sam back in a certain extent, but a new version of Sam.
Right. And that's true. One of the things that is a great kind of underscore of that is I tell people this all the time. Even after 2 years of abstinence from alcohol,
Mm-hmm.
that's when you start to see the sleep disruptions from alcohol dissipate. People can still have disruptions from alcohol because of the impact it had on its brain on sleep for up to 2 years. The same thing is true for their decisions,
Wow.
their personality, all of that stuff. So you're absolutely right in saying that does have to be some compounded time of away from the substance to rebuild who that person fundamentally is and to
Mm-hmm.
be able to know that the consistency of their decision making will return to kind of what you saw prior to the heavy opiate use.
Yeah, exactly. And when I was doing research to do the TED Talk, one of the doctors that I talked to and one of my friends that I talked to that was in recovery said to me, addiction takes the first position in your brain relative to survival. And so that's why, like you said about the mom with the overdosing with the kids in the back, if it's in first position, it overrides everything. And so there is no, like, you can't think about this the same way as somebody whose brain's working well.
Right. Another analogy that I use with families to help them understand what these people are going through, I said, they're out on the ski mountain and they're not going down the hill for the fun of the thrill of the ride. They are freezing. They are naked and they are trying desperately to get into that lodge. It
Mhm.
is not about the excitement of use. It is about the distress they're in when they're not using. That's what they're
Yes.
trying to remove.
Yeah.
And that's it. That's the addiction, is that it is this really deeply negative emotional state that takes over, that's driving the bus.
Yeah. And I remember a moment of watching him in that desperate place and knowing that at that point there was almost no way to intercede. It was just taking place in front of me. And it's incredibly heartbreaking to witness that.
It is. We had this young woman that was hospitalized with us, and opiate addiction is the hardest one. There, of all the addictions, the level of impaired distress tolerance I see in people struggling with opiates is significantly more than other
Hmm.
substances. So we had this
Hmm.
young woman that was hospitalized with us, and I knew, always around kind of day 4, day 5, people really start to struggle of the detox. So I kind of saw it coming, and she was like, "Listen, Dr. Swift, like I'm gonna leave." We went through all the things, and she kind of got it. And I said to her, I gave her my card, and I said, "Here, take this. Like, I
Hmm.
know that it may not make a difference, whatever." I woke up at like 5 o'clock in the morning the next morning. She'd called and emailed me multiple times because she realized she made a mistake. And so I called her back at like 5:30 in the morning and she was like, "Can I come back in?" And I was like, "Absolutely. Come back in."
Hmm.
And when she got back, she said to me, she's like, I never would have been able, I would have just kind of written it off if you hadn't given me that card. And I kind of knew, I knew she was going to struggle and I knew she was going to regret it. She couldn't
Mhm.
overcome the desire to leave and use at that point. But the real motivation inherently still
Mhm.
was there. It's just a
Mhm.
battle. And I couldn't force her to stay, but I had to give her the tools to climb back out of the hole.
Yeah, I'm kind of struck by your ability to see into the person and see the spirit that resides there and their magnitudes of spark, so to speak. And so you saw enough of a spark to give her your card. And then I know there are the times when, and I know this was my experience too, is the spark wasn't there.
Yeah.
I mean, I knew it was there somewhere, but it wasn't there enough to kind of feel like we might have a chance here.
Right. I've said that to people when they refuse to come to our rehab here. They'll come in, they're doing, I'm just doing detox. I'm just doing detox. And I'll explain to them why, we do recommend rehab. I'll ask for permission to explain it and then I'll explain it. And I'll say to them, I'll say, listen, I hear that you're not going to come right now. I said, will you just meet with our doctor from rehab just so that if ever in the chance that you need it, right? We plant seeds in the ground. We don't expect flowers to go tomorrow, but
Mhm.
if you water them, you give them sunlight somewhere they grow. So I'll say, will you
Mhm.
meet with our doc? Because I know that this isn't the right time for them now, but I want
Mhm.
them to have that personal connection. So when they
Mhm.
do feel ready, they'll come.
Mm. Right.
Because it's so important to just not, it's always worth that extra effort to plant the seed. Some
Mhm.
seeds never grow, but we can't tell it by looking at the ones we're putting in the ground, what's going to spurt up. So you might as well put them all in the ground, give everything down there.
Well, and I do think that it's super important for those who are dealing with the disease to know somebody cares. Because for the most part, they're just kind of out there and in all different kinds of configurations, multiple arrests and homelessness and all of the things that happen because of this disease. And then it feels very isolating.
Well, that's the other thing is that many of these people come to these settings having alienated a lot of their family.
Right.
Particularly with opiate use disorder, which, like we said, it kind of changes your decision making pattern where they've probably engaged in some behaviors that are not characteristic of who they are as people,
Hmm.
but were driven by addiction, lying, stealing, all of
Hmm.
those things. And
Hmm.
so they really don't have personal connections. And humans, most of us thrive on that.
Yeah.
So if it's appropriate in a boundaried way, we can build a connection with this person so that they don't feel
Hmm.
so lonely. And then maybe they see the worth in themselves again, because most
Hmm.
of these people really have low self-esteem by the time we get to them. They don't want to be doing what they're doing. They don't feel good about that. And they don't
Yeah.
have anyone around them that they love in the way that they used to.
Right, right. I think about all the things, and I don't begin to know maybe a tenth of what happened to Sam in the course of his dealing with the disease, but I know it was trauma upon trauma upon trauma upon trauma. And I mean, honestly, at this stage of the game, I think it's just a freaking miracle that he is where he is right now, given that notion.
The trauma piece cannot be ignored. And I talk about this with patients that are struggling with addiction all the time. Some of them don't identify that it's been traumatic, but putting yourself in a vulnerable state day after day where things can happen to you that you don't have full control over,
Mhm.
and also feeling tied that something external is controlling your life is traumatic. And trauma leads to this hypervigilance, this feeling of fight or flight, and you're always on edge. And so
Mhm.
having this kind of ambient agitation around feeling out of control can be something that we can talk about so that we can help dissipate it and quiet the
Mhm.
noise.
Well, and that's true for us too.
The traumatized family, I mean, it has to be talked about. It has to be. Otherwise, we
Yes.
can't heal it. We can't heal the family system without it.
Right, right. Well, and I know, I mean, it's been over 2 years, and every once in a while, this little thought will pop in my head, and I'm like, "What are you doing here? We're not doing that anymore." And so I think they're like little test bubbles.
Yeah.
Like, how resilient are you now? Like, how much more work do you still need to do?
It speaks to the idea that there's the person in recovery and then there's the loved one that also it's going to be a lifelong journey to
Mhm,
continue to know what's salient and what's not right now, what's past, what's
mhm,
present. And
mhm,
if you aren't aware, I mean, you're incredibly insightful and aware about it, but many people don't have that opportunity to be. So
mhm,
then they come back to the patient, the loved one. They say, are you using, is this that? Were you short with me because you did cocaine? It's all
mhm.
of the things that were the past, but they don't realize that it's just their own kind of calibration. How resilient am I today?
Right. And what I would say is, I think I've dedicated like so much time, effort, and energy to be where I am today
Right.
because it was important for me to do that. And it continues to be important for me to do that. That's why we're having this conversation. That's why I keep doing this podcast. Is it is another way of my own mental health and self-care to have these kinds of conversations with somebody who's in the trenches and understands all the crazy, all the chaos, all the disruption, and has seen successes on both sides.
But that's what I say to the family members in some of these episodes of treatment is I say, one of the things, and I don't, I'm not identifying you, mom, dad, whoever, as a patient, but I would strongly recommend you getting some sort of support because
Mm-hmm.
as you described, this is going to be something that the loved one needs to improve their functionality around. And
Mm-hmm.
it's not going to happen overnight. Just because somebody gets sober doesn't mean that all the trauma that happened to the family system is going to go away.
Right.
It takes work.
Yes, absolutely. And I think a lot of people think if they would just stop drinking
Right.
or they would just stop using,
Right.
everything would be fine.
Right.
And having done this with my mom, my brother, my ex-husband, and my son, wow, that is almost laughable, honestly. And so for me with my son, that was the one that like cracked me so wide open from a heart and spiritual perspective. I was like, okay, well, this is here for a reason. So I'm going to lean in and do the work that this opportunity presents me with.
And it's something that I think is inspiring for others because you didn't, despite addiction, literally in every point of the star around you,
Yeah.
you didn't get dragged down, right? Like it wasn't
Mm-hmm.
a poor me, wasn't as why is this happening to me? It was okay,
Mm-hmm.
I am tough enough to do this and let my experience help others see that even
Mm-hmm.
though sometimes we're laying on our backs in the, in the middle of a dark forest, if you stand up,
Mm-hmm.
you might see a little light. You might be able to find a path, right? There's going to be a break in the trees. But some of them are, you're laying on your back in the dark forest, it feels like it's over.
Oh, yeah. I mean, I've had tons of moments, the ugly cry on my knees, all the things. It's
Right.
just, I've always risen.
Right.
And so you create a resiliency of rising and continuing to learn, like I said earlier. And so one of the things I'm super curious about is what are the things that you're seeing now that are emerging in treatment for families and for those dealing with substance use disorder that weren't available 20 years ago?
So I think one of the biggest things is we have to normalize the acceptance of medications to control opiate use disorder.
Mm-hmm.
They save lives. We have to denounce the notion of these chemical handcuffs and all of these things. I have this conversation around buprenorphine all the time because people will
Mm-hmm.
be like, I don't want to be addicted to something else. And I'm like, well, take the word addicted out. You're wearing glasses on your face right now because of the
Mm-hmm.
way you want to see the world. I put contacts in my eyes every morning because I want to see clearly. It's the
Mm-hmm.
same consideration. We could do life without it. It's significantly harder, and
Right.
sometimes it's more dangerous. This is something that we, as a medical profession, needs to destigmatize, and as a general population, need to destigmatize. And on
Mm-hmm.
our end, what my goal, sometimes some of my last decade of work has been trying to get general practitioners and everybody more comfortable with buprenorphine. Because guess what? By the time they get to me as an addiction psychiatrist, it's probably a very, very entrenched substance use disorder, but they
Yeah.
can see their GP every year, hopefully.
Mm-hmm.
That's when you could make a decision about just towing the line, planting the seed, and seeing. And if the second the patient says yes, give them a script. Fine, they can come to me after, but strike while the iron's hot. So that's one of the things. And then the other thing is, and this is big for adolescents, and this has been one of the things that we at Silver Hill are trying to kind of support our local community, talking to parents about how to talk to teens about substance use and young
Yeah.
adults because we have to get in the conversation early. Their brains are
Yeah.
still developing. It really matters for them. It really, really
Mm-hmm.
does. And so that's one of the most vulnerable populations where I think more of the attention has turned and should continue to be focused on.
Yeah, I totally agree. I mean, when I grew up, which was in the 60s, really, and we didn't have fentanyl. One little piece of that and you're done. We just didn't have that to deal with. And I think, for a parent, that changed the game. When I found out that Sam was addicted to fentanyl because heroin had been sucked off the market, I was like, oh crap, we're in a different place now.
You're playing Russian roulette now. It's
Yes.
before, and I talk about this with people all the time, that's part of the problem, honestly, is that the older generation is more permissive of substance use because it wasn't as
Hmm.
dangerous. The
Right.
black tar heroin of the 70s was a warm hug. The
Hmm.
fentanyl of today, the xylazine, all those things, they literally put you into a stupor and can kill you on for, at the with one use. It's
Right.
just apples and oranges. And that's why we really have to take a much more dedicated effort to having people understand that we are not talking about, there's been such a shift in the potency of every single drug besides alcohol, honestly, that we have to pay attention.
Yeah, totally in agreement. So here's another curiosity that I have that I've actually thought about relative to Sam is what do you do with patients that need pain medication?
So this is what I tell them. There's a couple of things that we look at every patient's individual, but what I will tell them is that when you're treating people's pain, you're not treating to get a pain level of 0, you're treating to improve functionality.
Hmm.
So if somebody who has a history of addiction, they need some pain regimen, then you find a way to dose it or administer it in a way that's still safe, that they improve functionality. You're not looking for a pain score of 0, so you're not trying to, get them high essentially and
Yeah.
completely distracted from life. But nobody should be, just a history of addiction or anything like that should not preclude you from having the treatment that we all deserve. It just
Hmm.
means you might dispense it differently. And that's more work for us, but we should do it. So if you
Hmm.
have a history of addiction and you just had a hand surgery and you need some Percocet, fine, but give them 5 Percocet. Have them come back in more frequently, check in. If you're going to put them on fentanyl patch, mark the patch, do all the things to make sure that they can get what they need, but in a way you feel safe giving it to them.
Right. I'm curious again, are you seeing differences throughout the country of how all of this is thought about and administered? And because I had an interview, this was maybe a year and a half, maybe 2 years ago, with a mom who his her son continued to have health issues where he had to have pain medication and right back in addiction again because the doctors didn't know what the heck they were doing from that perspective.
So absolutely. It's unfortunate, but pockets of the country, they have no awareness or attachment to the idea that the more you put in the supply, the more problem we will have. And just having judicious prescribing it's focused mostly in the Northeast. I practiced for over a decade in the middle of Manhattan. Now I'm in Connecticut, but even in Connecticut, it's way worse than it was in Manhattan. People are just less thoughtful about it. And here at Silver Hill, we have people coming from all over the country after getting in the situation you just described, where they had some medical event, were prescribed pain medication, addiction lived in their history and they were off to the races. Or addiction lived in their family history. They didn't realize that it was going to be a problem for them, but the introduction to it, lit the match. But,
Yeah, it's
no, I
just
was
a
just saying,
tricky navigation.
it is, because I can't change the way that people prescribe across the country. I can just be here to have people know that we're a resource to help if you find yourself in that situation. Where I've had a physician called me and he said, I don't know what happened, but I was prescribed this and now I've taken more. I can't stop. I'm running out. What do I do?
Right.
I said, come in for treatment. But it surprised him.
Yeah. I think there's a bunch of people walking around that have been surprised. And it's partly, I think this would be the story I would tell. It's caught up in the shame, the judgment, the stories that we have about, well, this just happens to low lives.
Right? No, I mean, I tell this with opiates, you can really see it. There are two types of people with opiates. There are people that take an opiate and they feel good. They feel whole. They feel something, it's the warmness. And then there are other people that take opiates, which I happen to be one of them. It makes me really nauseous. Like when I had my
Hmm.
wisdom teeth out. But when
Hmm.
you describe this to people, typically you get two groups in the room. Some people be like, oh yeah, I can't tolerate them. They make me feel awful. And the other people be like, no, I actually feel really good on them. And it's just kind of indicative of, we're all going to be exposed to opiates somewhere in our life, right? Like that's inevitable. But the people that don't realize that good feeling and lean into it too much is where they get
Hmm.
themselves in trouble. And many people don't. Like I had a friend who had same situation, like he had a accident and was on opiates for a little bit. And when he came off, he was like, wow, I did not realize how different I felt on them. He's like,
Hmm.
I felt good, but he's like, when he came off, he's like, I was so foggy. I was not clear, but he didn't see it
Yeah.
in the moment.
Yeah. I remember this was years ago. I fell down the stairs and I fractured ribs in my back and they totally drugged me up. And I was like, well, this is awful.
Yeah.
And
Yeah.
it didn't really have material impact in the pain I was experiencing. And so I was like, well, what good is all this?
But
So
that's probably speaks to the sea of addiction that you've lived in and that live in your genetics, why you don't struggle yourself. It just didn't land DNA in that way.
thank goodness. And I'd also seen enough destruction that if it kind of had landed, I would have been getting help.
Right. You had the
So,
awareness to know that if it had, you would have been like, oh, okay,
oh,
this
this is
can't
not
happen.
gonna.
Right.
Yeah, we're not walking down this path. Um,
Right.
yeah, yeah. So, is there something I should have asked that I haven't asked so far that is really important for you from a messaging perspective to loved ones?
I think that the biggest thing that I would say is we as a society should have compassion for the loved ones of people that are
Mhm.
addicted. And the thing that you brought up earlier is that's honestly the message is like, don't villainize them for having somebody that struggles with addiction in their family. Be curious. And I think that the thing that would honestly, like, I would love to get out of this is if people need help, like, they can always call a treatment center on behalf of a loved one just to find out the information. Because
Mhm.
what is useful is when the person is ready, knowing what to do to connect the dots. Even if they are
Right.
in the throes of addiction right now, if you already have a plan that you could pull out of your pocket for when they're ready, then you're not scrambling in crisis. And so that's part of, a lot of what we do here at Silver Hill is that we have this incredible admissions team that family members call all the time to get information about
Mhm.
what to do
Mhm.
so that they have it kind of loaded for when the person's ready, which
Yeah.
I would say should be something that we should all feel comfortable doing.
Yeah, and I want to applaud you and kind of give an exclamation point around that because of having been to 12 different treatment centers. That was not my experience. And I've had some interviews with some extraordinary women in particular that run really awesome places like yours, and they approach it the way that you do, and so on and so forth. But I remember going to one treatment center and they were supposed to be something family and there was nothing. And so I remember sitting waiting to see my son. And I finally went to the front desk and I said, okay, can you give me a book or a video that would be really helpful for me to watch or read?
Right.
And they gave me Pleasure Unwoven by Dr. Kevin McCauley. And that video, I had to get it myself and all the
Right.
things. But that video, in and of itself, changed how I viewed my son's brain. But if I hadn't asked, I would have gotten nothing.
Right. And I think that that's where we have to understand that, yes, there's one person we're treating, but it's a whole system and we have to have
Mhm.
resources for everybody. We're going to have the medications or the DBT skills or whatever we're using, whatever modality the patient's getting, other people that are in the room, even when they're not in the room. And
Yeah.
they need resources and support too. So I
Yeah.
think, and the other thing that you're saying is that there are a million treatment centers. You got to do your homework. Everybody's website's going to look good.
Right.
Nobody's going to be on their website being like, this is terrible
Yeah.
care. Come to us.
We're not going to deal with the family. Yeah.
Right, right, right. That's not their tagline. But
Right.
you really want to get a feel for somewhere so that you know that you're getting good care and that
Hmm.
somebody is going to approach your loved one in a time of crisis with compassion, support you, and really you're going to feel like even if this one treatment episode doesn't produce sustained results, that you feel comfortable trying again. Just because if you go to the
Hmm.
supermarket and you buy food and you don't like what you made with the meal, you don't not ever go to the supermarket again. You might buy
Right.
the exact same food. You might try the exact same meal again, and maybe this time it works.
Right. Right. Exactly. I mean, I think there's a level of persistence that most people don't think. It's like they
Mhm.
try something once and then, like you just said, or they might try it twice. But I mean, this is a lifelong thing.
It is. And I say this to people all the time. Say, why should I go back to rehab? I said, because you have all the food in the fridge and you still didn't know how to make the recipe. So
Hmm.
now that you know what food's in your fridge, look at the recipes again with a different eye. It may taste good this time. You have to be open to trying again. You fall down 7 times, you get up 8, right? Like you have to just be,
Right.
like you said, persistent and resilient.
Yeah. Okay, so we're coming up against the edge of our time, which I'm so disappointed in. But what do you do for self care?
So I think that there are a couple of things that I think are really important. One is I take 30 minutes a day to exercise always
Hmm.
because you have to take care of your mind and you have to keep your body moving. It dissipates the ambient energy that might be living in your mind. And I think that it is really important to be intentional about the interactions in your day. So,
Yeah.
kind of what we started talking about early, we have to surround ourselves with people that bring out positive feelings, and
Hmm.
so sometimes we can't avoid it. But what I try and do with my everyday life is spend time with people that I have positive interactions with. I don't villainize myself for not wanting to spend time with people that I don't enjoy.
Good for you. I'm very anti vampire.
Yes.
No vampires allowed. So then I am really curious also to just really, I keep coming up with these questions for you, but how do you keep from losing hope?
That's a great question. I think that you have to see that one disappointment doesn't dictate a future. And
Hmm.
that there's always, maybe I am just a person that can see the positive in things, but I'm not a Pollyannish person. Like it's just that I've seen enough to know that even when things look terrible, it
Mm-hmm.
can turn around. I used to say this to people, everybody has their last high. Those people that choose to not use again get to talk about theirs, and those that unfortunately succumb to the disease don't. But everybody
Right.
gets one last high. So there is the opportunity for this one last high
Mm-hmm.
to be the one that you talk about 10 years later in a room somewhere. And
Right.
I think that it's just having seen so much of it. I know that there are going to be sad cases, but overwhelmingly, there are outcomes that we can celebrate. And maybe some of them aren't full recovery, but they're approximations of things. So there's always hope for something.
Well, I just want to say thank you for who you are in this work and what you're doing and all the lives that you're affecting. It's not just the person that's dealing with the disease. You affect the families, and those families affect more people. And the ripple effect off of what you're doing is profound. So, as a mom, I want to just say thank you.
Of course. Well, thank you for having me and allowing me to be able to hopefully impact others that don't know who to reach out to, when they have a loved one struggling with addiction, because they always they could call us, they could call, any of these places, hopefully be receptive. But I could tell you that our place will be receptive and I would be receptive.
So, as a closing thing, tell them how to get a hold of Silver Hill.
So what I would say is we do have a website, which is silverhillhospital.org, but I can also tell you my email address is aswift, like Taylor Swift, at silverhillhospital.org.
Okay.
But if you ever have a question, and I could direct in the right place.
Great. And remember, people, they take people from all across the country.
Yep.
So if your experience has not been at the caliber that you want it at, and you want really high level care that is integrated on all the modalities with somebody like Dr. Swift, who obviously you can all tell this is a heart calling for her, call, reach out, ask for help.
Thank you so much for having me.
Absolutely. Thank you.